We're going to talk about perimetry here for glaucoma diagnosis and progression. There are two common type of printers that perimeters that we use. Projection perimeters. This is what a typical octopus printout looks like, and this is what the Humphrey printout looks like. Now the question that we're going to ask ourselves is, why is it that we want to do perimetry? Now if you look at this, the only way we can document a structural damage to the optic disc is as a functional loss on perimetry. So you see this optic disc, there's marked thinning of the inferior neural rim, and therefore you have marked changes at the superior hemisphere of this visual field printout. There are changes at the superior pole, and therefore you have changes in the inferior hemisphere also. So it's important for us to document the visual field on perimetry because it's an important symptom of a disease. And if you see this chart which correlates structural loss with functional damage, you will find that visual field changes happen when 40% of the ganglion cells are lost, even though the disc and the nerve fiber layer changes happen before the functional loss actually can be documented. But visual field loss, it's an important disease symptom, and for this reason, because structural damage usually precedes the functional loss, the visual fields are affected late in life, late in the course of the disease, and they tend to affect the patient's quality of life. Patient's quality of life is affected more if it's a bilateral visual field defect. It's affected more if it's an inferior visual field defect, or when there's a lateral field defect because it interferes with this driving process. So is perimetry important in the management of glaucoma? Yes, because if you see if you look at definitions for glaucoma as they go, the normal statistical range of intraocular pressure is 11 to 21 millimeters of mercury. When you see a patient who has a pressure more than 21 millimeters of mercury, you have to get his visual fields done, and then the diagnosis becomes ocular hypertension if the pressure is raised, angles open, whatever be the status of the disc, if the fields are normal, it's ocular hypertension. For the same reason, if you have pressures more than 21 millimeters of mercury, open angles on gonioscopy, disc changes with correlating visual field changes, the diagnosis is an open angle glaucoma. So that's how fields play an important role. Again, look at the other scenario. Pressure less than 21 millimeters of mercury, structural changes to the optic disc, correlating functional loss on perimetry, your diagnosis would be suspected damage at a low intraocular pressure. And then you would proceed subsequently. So perimetry is important to document the existence of the visual field damage that we get, simply because field defects are an important and a reliable sign of disease. Take a look at this optic disc. How many people feel that this is a normal optic disc? Can you raise your hands? So most of you think that this is a glaucomatous optic disc. Now, this is an average size optic disc with a cup disc ratio of 0.6, 0.7. The inferior rim is wider than the superior rim. The temporal rim is wider than the nasal rim. Why would you think in terms of glaucoma? A large cup disc ratio does not mean glaucoma. Now look at the optic disc of the other side. Average size disc, inferior rim narrower than the superior rim, and the other positive finding is a nerve fiber layer defect. And when you see these two optic discs, same patient, you will obviously think in terms of glaucoma, right? But remember that when you saw one eye, you weren't very sure. The inferior rim asymmetry is again another telltale sign. Are these optic discs glaucomatous? No. Now if you look at the optic disc here, it's a small size optic disc, and small size optic disc should have no cups. When we saw this patient, we got the fields done for the raised intraocular pressure as a part of our routine workup. We found that there was an inferior nasal depression consistent when we repeated the fields. Dilated and examined, felt it was still normal, and I'm actually showing you a mistake. There was a nerve fiber layer defect here correlating with the field change that we were seeing. I had missed it on my initial thorough examination. Now let me tell you the other side of the picture. This happens to all of us in our clinics. It's been documented that large cups and physiological cuppings are very often mistaken for glaucoma. In a short study that I want to tell you about 220 patients, the correct diagnosis could only be made in about 80%. More importantly, 20% patients were not diagnosed correctly. So this was about large size optic disc. The error increases when you're looking at small size optic, because in the same cohort, in the same study with a different cohort, they found small size optic disc, they were more likely to miss the diagnosis in about 40% of the cases that they saw. So all I'm trying to tell you is you cannot rely on optic disc evaluation alone to diagnose your glaucoma, and visual field examination is an integral part of the diagnosis procedure. Now, and for this same reason, visual field testing should actually be a part of our standardized care for glaucoma patients or suspects. The other reason to do perimetry is to be able to assess whether the patient's glaucoma status is stable or progressing over time. Now, progression in glaucoma and on perimetry would be a new defect in an area which was previously normal. There could be deepening of a pre-existing defect. A pre-existing defect could expand, and the entire field now gets a superadded reduction in sensitivity. There are several ways you can actually do this, and whenever you suspect progression, it's important to repeat the fields over a period of time. So when you see these octopus fields over a period of time done in April 99, November 99 and December of 2000, let me show you this change in a... So the question that you're coming to ask is, are you looking at a fluctuation or are you looking at a progression? Look at the individual fields and you're still not very sure about them. And this is what happens when you keep fields together as an overview to assess progression over time. The octopus uses a trend-based analysis to assess progression. If you're a Humphrey user, you could use the event-based analysis. You have a baseline examination, you have the visual field index, and the change probability from the last visual field with probability symbols to tell you about the possibility of a progression. So remember what happens. This is the actual data. This is the extrapolated data to give you a 5-year change or an event, what would be the change in the next 5 years. And when you look at visual field index, it's a very complex process, and the important thing is the International Glaucoma Society suggests that the mean deviation be used to assess progression and not the visual field index. So when you see fields like this, these were the fields done long back, and look at the fields done and look at this change here. And even though intraocular pressure for this patient remained in the 8 to 12 millimeters of mercury, he had progressed. But then, was it a fluctuation or was it progression? Look at these octopus fields over a period of time. On the right hand side, on the upper side is the right eye, all over time. And then you see the left eye, and you're asking yourself, is this a progression or a deepening of the scotoma that we are seeing here? So when you're looking at the progression analysis, the mean deviation here on the trend analysis will tell you whether the fields are getting worse. You look at the square loss variance to assess whether there is a deterioration. It also shows you a deterioration, but this deterioration could be because of a diffuse defect, that is a non-glaucomatous change, which you look at here in the diffuse defect, and that part is stable. Look at the local defect, and it tends to show you that there is a progression of the visual fields that is happening. So it's easy to pick up progression here for the left eye and say that there is a change, and this change then gets quantified, and you can get the rate of change per year for this patient. And that can be, they have probability symbols to tell you the possibility of such a change in a glaucomatous population. Again, take a look at another example. The right eye is more or less stable, and the left eye is showing a change. There's a deepening of the scotoma in the upper quadrant and a new scotoma appearing in the lower quadrant. You can assess this change that the mean deviation is showing a deterioration, that is the hill of the island of vision, while the square variance remains the same. The local defect remains constant, and it's the diffuse defect, that is the changes from the cataract, which are getting superadded and causing the discomfort here for this thing. So another way here is to ask yourself, is the cataract masking the deterioration of a possible glaucomatous field effect? And that's where the corrected cluster helps us to examine the patient, and you realize there is a deterioration, but it's a focal deterioration. That is, the cataract change is masking a glaucomatous change in the inferior part of the visual field. And this is how it appears in terms of, again, you have probability symbols here to give you an idea about progression. The other way is you can do a point-to-point analysis on what is called as the polar trend on the octopus perimeter, where the red represents a worsening and a green represents an improvement. The values are in decibels over a period of time. Quickly show you this patient. Large size optic disc. It's important to document this change to make the right diagnosis. And it's also important to monitor the glaucoma over a period of time to assess deterioration. That's why we need perimetry in the management of our glaucoma patients. Thank you very much.